Real life.
So, welcome friends. Good evening to everyone. This is AIOS initiative on walking patients. Today's item is uveitis patients, and we know that these are problematic area for comprehensive ophthalmologist, and the lecture is made in such a way it should be beneficial for comprehensive ophthalmologist. So this is from AIOS headquarters. We are going every alternate week on different subjects and specially made for the comprehensive ophthalmologist. With that note, I hand over to Partho. Partho, you can now take the chair and you can start the session.
Thank you, sir. So, good evening, friends. Welcome to this interesting webinar. I'm your host, Dr. Partho Pratim from Shankar Nethralaya, Chennai. So, me and my co-host, Dr. Rohit Modi, will be moderating today's webinar. Dr. Rohit Modi is a dynamic vitreoretinal surgeon and uvea specialist from Snetra Clinic and Hospital, Mumbai. So, we sincerely thank Team AIOS for giving us this opportunity to host this webinar on such an interesting topic. So as we all know, the recognizing clinical signs is the cornerstone of managing any disease or any entity. Now, a clinician's entity usually judged by their ability to identify these signs, clinical signs in their day-to-day clinical practice. So here today evening, the 8 speakers will give us insight on 8 specific clinical signs of uveitis and followed by a lot of interaction and discussion from the experts we have in this webinar. So now may I request Dr. Rohit Modi to introduce our panelist. Over to you, Rohit.
Thank you, Dr. Partho, for the wonderful opportunity. Now I would like to invite our esteemed panelists who don't require much introduction. Dr. Jyotirmay Biswas sir, he is the director at Uvea department, Shankara Nethralaya. Dr. S.R. Ratinam ma'am, who is the chief of Uveitis services and principal of PG Institute Ophthalmology, Arvind Eye Care System. Dr. Soimava Vasu, network head Uveitis services, LV Prasad Eye Institute, Hyderabad. Dr. Ramandeep Singh is professor at Advanced Eye Center, PGI, Chandigarh. Dr. S. Balamurugan, Chief of Uvea Services, Arvind Eye Hospital, Pondicherry. Dr. Somshila Murthy, she is the medical director, also the head of cornea, cataract, refractive, and uveitis services, Shantilal Sanghvi Eye Institute, Mumbai.
So, our first talk is by Dr. Elijah Anthony. So, Dr. Elijah will be, Elijah is a renowned consultant in Arvind Eye Hospital, Chennai. So, she will be giving us the insight on our first clinical sign, Hypopyon. Elijah, over to you.
Thank you, Partho sir, and I convey my good evening to all the respected panelists and moderators and AIOS for giving this opportunity. So I'll be discussing, am I audible? So I'll be discussing regarding Hypopyon and how to differentiate Hypopyon associated with uveitis with endophthalmitis and masquerade, that is pseudo-hypopyons. So the first important tool is to take a very good history. So in any case of Hypopyon, even when we suspect inflammation, it's very important to take history, which would give us clue whether we are dealing with infection, like history of recent fever, any septic foci, recent surgery, injections, uncontrolled sugars, history of trauma, And some of the drugs like rifabutin in immunocompromised patients, they also cause hypopyon uveitis. Again, history to rule out any autoimmune disorder, that is also very important. So history is very crucial whenever hypopyon uveitis walks in on our OPD. So this is a case of a 30-year-old female who presented with 2 months blurred vision, and she had pain and redness since 3 days. On examination, she had a mature cataract in right eye. Vision was hand movements. So we, along with the mature cataract, there was a streak hypopyon, but to mark no keratic precipitates. So we here suspected a fast progressive cataract secondary to leptospira cataract with hypopyon. Our second ED was phacolytic. So we started patient on hourly topical steroids, antibiotics and cycloplegics, and oral azithromycin. So you can see on the B scan also, there are a few posterior vit echoes, but we kept a close watch. Now, on the second day, we can see the posterior echoes on the B scan have worsened. There was subtenance widening in certain areas, and RCS thickening was noted. So clinically also, there was worsening of hypopyon. It increased to 1 millimeter. So at this point, our diagnosis was endogenous endophthalmitis. So even though it looks so much inflammatory at the first sitting, it is very important to keep a close watch. And whenever we note worsening to hourly Predfort, to step down the Predfort, and then we continued frequent antibiotics. So we planned Vitritis and AC tap, which showed coagulase negative staphylococcus endogenous endophthalmitis. So it was treated accordingly. So the important things to in the workup of uveitis will deal case wise. A word about ESR CRP. This is a very important investigation because it not just tells you about underlying autoimmune disease, but also gives you an idea if you're dealing with a underlying systemic infection because it will be elevated. So in endogenous endophthalmitis, you can note high ESRs and CRP if there's systemic infection. Again, you have to screen all patients for syphilis because it has protein presentation, and it can present with hypopyons. So this is a case where a 36-year-old male presented with hypopyon uveitis. It was very fibrinous, painful red eye, alternating in both eyes. He gave history of morning back and neck stiffness. So we suspected B27 and it came out to be positive. So imaging also showed sacroiliitis. So whenever we see this history of fibrinous hypopyon uveitis alternating in both eyes, we have to suspect HLA-B27. The other diseases in the spectrum of HLA-B27 positive disease is reactive arthritis. So here urethritis will be there. So urine routine micro should be done. Psoriasis with arthritis, again, general examination is enough to detect psoriasis. Again, history suggestive of inflammatory bowel disease should be taken. Now, based on the severity of disease, you can plan biologicals, immunosuppressives, or oral steroids. Rheumatology referral is very important because all these diseases do have systemic implications. Now, the second most common cause of uveitis with hypopyon is Behçet's disease. So here the eye is apparently white, minimal congestion. So it's called as a cold hypopyon. Then the hypopyon here, unlike B27, are mobile hypopyon. They demonstrate shifting with change in head posture. This is because these hypopyon have more of serous protein than fibrin. Now, again, you have to take history of recurrent oral and genital ulcers, history to rule out other systemic manifestation of Behçet's. B5 association is very important because it's strongly associated with dementia Behçet's. Again, Behçet's is a sight-threatening disease. So you have to do a good fundus examination because it can be associated with arteritis, which can cause an early optic atrophy. Systemic implications are also important. It's an aggressive disease, so rheumatology referral is mandatory in Behçet's. Coming to the mobility, as we have discussed, shifting mechanism, it's also seen in pseudohypopyons like Behçet's, even pseudohypopyons like masquerade syndrome, crystalline lenticular matter in anterior chamber, and sometimes when IVTA is used for uveitis treatment and there's a capsular breach, IVTA crystal tend to migrate in AC. So that can also mimic in uveitis a pseudohypopyon. So these are all mobile hypopyons and they demonstrate shifting. Now, again, lens-induced uveitis is very characteristic examination finding. Like this is an elderly 65-year-old female who presented to us with 2 years poor vision in one eye, with 1 week history of redness and pain. So on examination, she had a deep AC and ALC breach was noted. And we can see fluffy cortical, unlike cells, you will see fluffy cortical matter on the endothelium in the AC, and then the lens matter deposit in the form of pseudohypopyons. So these are not inflammatory, these are pseudohypopyons, and then management is always conservative topical steroid with the early cataract surgery. Post-operative hypopyon. Now, this is very challenging when it comes to uvea, when you have to rule out inflammatory and infective. So in any post-operative hypopyon, you have to have strong suspicion of infection unless proven. So keep the patient in close watch, assess response to steroids. Now, the hypopyons which come in the first 24 hours, the most important DD is toxic anterior shock syndrome. So they'll have good response to steroids and they'll have this limbal to limbal corneal edema. Sometimes the cause is very obvious, like you can see the cortical matter here, residual cortical matter, which can come with streak hypopyon. So again, good examination is very important and then treat accordingly. Pediatric hypopyon, first on the list is to rule out always masquerades. So if it is leukemia, CBC, complete blood picture with peripheral smear is very important. Always have suspicion of retinoblastoma in pediatric uveitis, so need to do a base scan. Toxocara uveitis is another condition which can come with hypopyon and leukorrhea in pediatric age group. So then again, take history of exposure to pets and B scan again is very important and keep a close watch. Post-viral infection hypopyon can come in children. So this was a child, 8-year-old, who came with hypopyon 10 days after mumps. So he had significant vitritis. So he's on topical steroids and oral steroids and he's doing well. So again, another group is juvenile spondyloarthropathies, which are HLA-B27 positive. Just like in adults, this can be seen even in the juvenile or the pediatric age group. So whenever we see fibrinous hypopyons in pediatric age group, even juvenile spondyloarthropathies have to be kept as a differential. And you have to take history of the same joint pain and arthritis in children. Now, apart from leukemia and retinoblastoma in adults, the another DD for pseudohypopyon or masquerade is vitreoretinal lymphoma. So whenever these hypopyon associated with dense vitreous opacification, especially in extremes of ages in elderly people, and you note poor response to topical and oral steroids, lymphoma has to be kept as DD. Now, this is a case of a retinoblastoma child coming with a pseudohypopyon. You can see the tumor seedings on the endothelium. So normally masquerades or pseudohypopyon are Uveitis uveitis, but you can see here there is ciliary congestion. So tumor cells tend to irritate the uveal tissue. So sometimes even in masquerade, you can expect minimal ciliary congestion because of the uveal irritation and secondary uveitis, secondary tumor cells. And the color of the hypopyon is also very important. Like tuberculosis can cause brown or pigmented hypopyons. Viral hypopyons can be blood-stained or combined with hyphema because viruses tend to cause occlusive vasculitis of the iris blood vessels. So again, when you see these atypical hypopyons, vitreous tab and AC tab becomes important. So this is a case by Agrawal et al. Where they have got a positive MAN2 and quantiferon in this pigmented hypopyon, and they've confirmed it with the TAP and culture coming positive for Mycobacterium tuberculosis. So in these atypical hypopyons which are not responding, again, vitreous and AC TAP become important, and especially again in endophthalmitis, it's important. Now, word about inverse hypopyons are classically seen in when emulsified silicon oil is seen in anterior chamber. So these patients will have history of surgery. Now, this was a single report published where there was an inverse hypopyon-like picture noted with infective scleritis secondary to pyomyositis, but here it more looks like a granuloma. So these conditions also have to be kept in mind in scleritis cases. So to mention about scleritis, this is our patient who came with unilateral facial edema and a severe tooth infection, and she had this temporal scleritis. The scleritis per se didn't look infective, but when we noted the fundus, it had an infective foci and a subretinal hypopyon. So this was an infective scleritis secondary to a tooth infection. So classically, inflammatory sedimentation happens in the anterior chamber, but atypical locations like in the cornea or in the capsule or even the subretinal hypopyon can be there. So in any case of scleritis, so this again shows history is so important, history in examination, general examination. So if you see infected tooth abscess, you have to suspect infection even in cases of scleritis when it doesn't look infective. And subretinal hypopyon has to be kept in mind. So with this, I wind up, and the takeaway points are: a good history and examination is the key when you deal with hypopyons. Keep a close watch even when you suspect inflammation strongly. Assess response to topical steroids. Any poor response to treatment, suspect infection or masquerades, and then plan on AC or vitreous step. Thank you.
Thank you, Dr. Eliza, for a wonderful talk on Hypopyon. I would like to ask Dr. Retinal ma'am, how do you approach a case of Hypopyon uveitis in your OPD?
Ma'am, you are muted. Can you unmute?
Elisa gave a wonderful talk. It was a fantastic presentation covering everything.
Thank you.
So the question is more of a generalized question. How will you approach a case of Hypopyon uveitis? As she correctly mentioned, it depends on various factors, including age, gender, and previous history, systemic association of diseases, previous events like trauma, and other masquerade syndromes. So she very well described the scenario where all you can see the Hypopyon. And also she mentioned the type of Hypopyon. So the type of Hypopyon and age and systemic diagnosis is the most important thing. And specifically, every one of us should remember that when there is Hypopyon, the uveitis comes under severe form, and the tendency for synechia is more when there is fibrinous reaction. So more importantly, in such cases, even before reaching the etiological diagnosis, our aim is to keep the people mobile. Most importantly, even before thinking about etiology, in a case of fibrinous Hypopyon, we have to keep the people mobile. That is my first approach nowadays, because in HLA-B27 uveitis, it often happens before we realize they go for ring synechia. Okay, now there is as she mentioned, there is a patient, a young male patient with the possible, with the associated low back pain and the fibrinous Hypopyon. It is very, very simple to diagnose and very easy to approach also. In such cases, we can directly go to the diagnosis of HLA-B27. As she also mentioned, in a rare case of CNS lymphoma, we can see a fluid level Hypopyon where the age itself will tell you. But the most difficult part is just a Hypopyon in case a recurrent Hypopyon in a middle age. I often think that we will miss Behçet's, early Behçet's in such cases. So in such cases, sudden fluid level white Hypopyon in a middle-aged patient, I repeatedly ask for mouth ulcer and genital ulcer, and even if it is not there, I do FFA to look for a vascular leakage. So such findings, such a broad view, it is not only Hypopyon, and we should not jump into the conclusion that it could be a non-infectious Hypopyon and start with steroids. We have to collect all this information, then we have to approach appropriately.
Thank you, ma'am, for your insights. Dr. Somshila, how would you manage a case of scleritis with Hypopyon?
I think more than manage, I think when you have a case of scleritis with Hypopyon, then the thought process shifts towards an infective etiology. So we have noted, and Dr. Ratinam and Bala, many over here would have seen cases which are infected or infective in nature. So the immune-mediated scleritis with Hypopyon, they may exist if the inflammation is practically unchecked and it spills over to the underlying choroid and so on. But if I see a recent case of scleritis, I start thinking of infection. A couple of points, if I can add, for Dr. Eliza's presentation. I think it was a marvelous presentation. Eliza pretty much covered the entire topic. I just recall in my mind one case where we had seen a streak hypopyon, a young male patient, unilateral granulomatous, what we thought was anterior uveitis. Pressure was 60 in a steamy cornea, and there was a streak hypopyon. This was all that we could see, and B scan initially appeared to be normal. So we, because of just the diagnostic probability, so we just went on a limb and we assumed that it's viral uveitis, and we started the patient on antivirals and of course IOP lowering agents and steroids. But exactly as you said, so luckily we kept a close watch. Next time the patient came in, the B scan began to show more and more echoes, and we could now notice that there was a vitritis. And this patient also turned out to be a case of endogenous endophthalmitis, and it was bacteria. So luckily we had a good result for this case. The third case that I thought of when you were presenting was post-cataract surgery. Of course, number one on your differential would be endophthalmitis. That is obviously if you see hypopyon after cataract surgery. But in controlled uveitis, there are a few cases which are very peculiar that they present with hypopyonia. And one of them is patients with leprosy. So Hansen's recovered or Hansen's treated patients when they have uveitis and then they have cataracts. So the clinical experience, I don't think anybody's reported, and the others could also share if they have a similar experience, that sometimes these patients present with quite florid AC reaction, which improves rapidly with steroids. So this is what I had to add to your presentation.
Thank you, ma'am. Next, I would like to invite Dr. Neetu Latif for a talk on keratic precipitates and iris signs. She is a seasoned uveitis specialist and a consultant at Giridhar Eye Institute in Kochi. Dr. Neetu.
Am I audible, sir?
Yes, you're on.
So I'll be talking about keratic precipitates and iris nodules. So to make it more interesting, I have included some interesting cases. Case 1, a young male, 27-year-old, complains of floaters in the right eye, vision 6/6 and 6 in both the eyes. He denies any history of systemic illness. Slit lamp photo of the patient. It was a white eye with no conjunctival congestion or circumcorneal condition. There were diffuse stellate fine KPs distributed all over the cornea. AC reaction of 1+. And as you can see in this picture, there were numerous nodules on the iris surface. We dilated this patient and the pupil was well dilated without, there was no posterior synechia. Fundus examination, the media was hazy because of dense vitreous membrane. But however, the disc and macula was normal. OCT macula was also done, which was normal. So the probable diagnosis in this patient is Fuchs heterochromic iridocyclitis. This clinical entity is often misdiagnosed because of its diverse clinical presentation. Heterochromia is one of the unique features of Fuchs uveitis, but it is more prominent in light-colored iris than in dark-colored iris. And also other factors affecting it is anterior stromal atrophy and the pigments in the iris epithelium. The differential diagnosis of Fuchs is Posner-Schlossman syndrome, wherein the patient presents with acute recurrent episodes of anterior uveitis, which will be more of a subtle inflammation, and the patient usually responds well with topical steroid, and the eye will be quiescent in between the attacks of anterior uveitis. Now, the role of corticosteroid is much limited in case of Fuchs uveitis because Fuchs is unresponsive to topical and oral steroids. And however, if you treat these patients with long-term steroids, you may land up in cataract and glaucoma. But however, you can try a short course of topical steroids in patients with symptomatic exacerbations. Case 2 is of a young male, 21-year-old, acute onset redness pain in the right eye. Vision 6/6 in both eyes. IOP is 36 in the right eye and 14 in the left eye. So this is the slit lamp photo of that patient. You can see that there are few medium and fine pigmented KPs distributed inferiorly in the cornea. AC reaction of 2+, and the fundus was normal. So this patient, I think the probable diagnosis is viral anterior uveitis. I treated the patient with topical steroids and anti-glaucoma medication, and he responded very well with medication, and he didn't come up with a recurrence so far. Here is a case of a 70-year-old male with history of herpes zoster ophthalmicus few months back. And he presented to us with left eye anterior uveitis. You can see that the large and medium pigmented capes in the cornea. And also please note the iris atrophic patches. The probable diagnosis is VZV anterior uveitis. VZV usually occurs in immunocompromised, and it can also occur in immunocompetent patients. A patient usually presents with large capes, segmental iris atrophy, raised IOP, and skin manifestations, which were all present in our patient. 51-year-old male with left eye redness, photophobia, and blurred vision since 5 days, vision 6.6 in the right eye and 6.9 in the left eye. IOP in the left eye is 25. So I just put up this case to show the D-shaped pupil in this patient. You can note down the D-shaped pupil and the iris atrophic patches. So even after treating with antivirals and topicals, this is 2 months follow-up. The uveitis is under control, but the shape of the pupil remains the same. Here is a case of a 20-year-old male, not case of cerebral palsy, sudden onset redness in the left eye since a week. And on examination, it was an acute granulomatous uveitis in the left eye. So this case I wanted to show you because I just wanted to emphasize the importance of fundus examination in patients with uveitis. I dilated and saw the fundus, and it was acute retinal necrosis, wherein you can see the retinitis patches in the periphery. So this is just the clinical signs in the 3 viruses you see. I'm not going into the details of it. Case 6, a 38-year-old male patient, sudden onset redness, pain in the right eye. Similar history alternating in both the eyes, vision 6.12 in the right eye and 6.6 in the left eye. IOP is normal and gives history of back pain and joint pain. So this was the slit lamp finding. You can see a hypopyon fibrinous anterior uveitis. So the first test I would recommend in this patient is actually B27, and that turned out to be positive in this patient. Here is another case, which is a known case of ankylosing spondylitis, presenting with redness in the right eye, similar history in the past, so I didn't have to check for the diagnosis. This was the slit lamp finding of the patient. You can granulomatous anterior uveitis. I just put up this picture to show that not all cases of HLA-B27 presents with fibrinous or hypopyon anterior uveitis. Even you get a mild or moderate inflammation. So in any case of recurrent non-granulomatous anterior uveitis, it is the first test you go for is HLA-B27. So we treat this patient with intensive topical steroids. I do start with Predfort every 15 minutes for a few hours and then shift on to 1 hourly. And a strong cycloplegic like atropine is given and refer to a rheumatologist in case of systemic involvement. Here's a case of a 13-year-old boy with acute onset redness in the right eye since 15 days. Vision is 6.15 in the right eye and 6.6 in the left eye. IOP is 44 in the right eye and 16 in the left eye. Here you can see a very faint hypopyon in the anterior chamber, and the iris appeared. So we did a AIOS-OCT, and you can just compare with the left eye AIOS-OCT. The iris appears more thickened in the right eye than the left eye. A UBM is also done. So then we took a detailed history, and we came to know that it was a known case of acute lymphoblastic leukemia. Remission since 2 years, peripheral smear predominantly lymphocytes, MRI brain and orbit was normal. Acute cytology, B lymphoblast in significant number was noted. So hypopyon at extremes of age always should think of masquerade. Iris infiltration commonly noted in acute lymphoblastic leukemia. Iris involvement occurs after leukemia is diagnosed, and a poor prognosis is noted in cases with ophthalmic involvement. So my take-home message is that the commonest anterior uveitis you come across is HLA-B27. Often misdiagnosed as Fuchs uveitis. Extremes of age group think of masquerade. A thorough fundus examination is mandatory in any case of uveitis you come across your clinic. Thank you.
Wow, that was an atlas of anterior uveitis. Thanks, Nikki. It was a nice presentation. So I'll go to our panelist, Dr. Somshila Murthy, Can you give our audience some clue how to differentiate pigmented capes from the pigments in corneal endothelium?
Yeah, thanks, Partha. That is a good question because often the two look a little bit similar, especially when you see a lot of pigments. So pigments are classically smaller. They're of course always small dot-like pigments, iris color, and they are diffusely spread. So on the other hand, KPs have a definite morphology. So they look, in the fresh cases, in the acute inflammation, they look three-dimensional. If you still have some doubts and you are not able to figure out, and you have expensive machines, then you can do an ASOCT where it's very clear because the pigments are isorefractile with the corneal endothelium, whereas the KPs will almost sort of hang out from the endothelium area. So basically it is the size, and when there are old KPs, that is when you can sometimes get confused as pigments. So you can look for the crenation of the edges of the old KPs, whereas pigments will be very small and indistinct. So once you see a couple of cases, then you can't miss it.
Thank you. So I'll go to Retina, ma'am. Madam, you are there?
Yeah.
So, madam,
I am
my
there.
question to you is, does mutton fat keratic precipitates always mean tubercular etiology?
No, not at all. Not at all. Mutton fat keratic precipitate. See, usually the granulomatous KPs can be different, can be classified as acute granulomatous and chronic granulomatous. In acute granulomatous, most of the time it is two-dimensional. It is just, it will not have the substance in it. That is seen only in viral uveitis and lens-induced uveitis. Mutton fat KPs are chronic granulomatous KPs that occur in non-infectious and infectious. In infectious, it can be seen in tuberculosis, leprosy, syphilis, all the three, and fungal granulomas. Whereas non-infectious mutton fat KPs definitely seen in sarcoidosis, VKH, and sympathetic ophthalmia. Mutton fat KPs do not always indicate TB. It has to be differentiated even in this chronic granulomatous mutton fat KPs, infectious and non-infectious.
Yeah. So point very well taken. So if you have to look into the other features and rely on the history and other investigations before you decide on tubercular etiology. So now from Neetu's talk, what we have realized, if we see that iris atrophy and the keratic precipitate distributing all over the corneal endothelium, and if it is there is any corneal scar, then one should suspect the viral etiology. Now, problem with us is often we start the patient on steroid, and the moment we reduce the eye drop, it again comes back. And often we have a problem that how long to continue the antiviral in these patients. So can you tell us that how long the antiviral should be continued in these patients with viral etiology?
In fact, it is a very, very difficult situation to handle virus, mainly because we are not handling one type of virus and one strain of each virus. Each virus is different, each strain is so different. So they behave very, very different, especially in patients with varying immune responses. Is it background noise somewhere? It is happening. Anyway, so because we have several strains, several viruses, and varying immunological response by the patient, one regimen or one particular way of treatment cannot be given. It depends upon each patient. So what I follow is valsiclovir 1 gram TDS oral I give for 15 days if it is only anterior uveitis, and Virsan ointment with topical steroid if it is anterior uveitis. If it is ARN, I give at least for 1 month. Then depending upon the response, I go. In case of EB virus, we don't have medicine. So it is only steroid and you continue and you just see the response. If it is CMV virus, cytomegalovirus, definitely valsiclovir is not enough. You have to go for the specific treatment, specific antiviral treatment, and that too valganciclovir, which is very, very expensive. So it depends again upon the response. So what I do is at least I keep the patient on 1 month if it is very resistant case. So ultimately the take home message is it is not one virus we are treating, not one strain we are treating. We are treating patients with varying immunological responses. So to have a baseline, we will see if it is anterior uveitis, we will give oral and topical antiviral and see for the response. If it is multiple time recurrences happen, then I keep the patient on 1000 milligram, one tablet for even for 3 months or 6 months or 8 months. If it is too many recurrences. That is what all over the world, even Dr. Foster does that. He even go to the extent of treating them with 1 day OD dose of valsiclovir for 10 years, if it is recurrently happening.
That's a very important point.
Yeah. Have I answered your question?
Yes, ma'am. Yes, ma'am. It was very insightful also. Ma'am, do you use ganciclovir gel?
Yes, of course, I use the gel. Because it is available in India, we have to use. Now, in America, it is not there. So, their literature do not support that. But when it is available, it is easy. And especially our patients are very poor patients. So, when it is a mild anterior viral uveitis, when they cannot afford for valsiclovir oral, I just give gel as well as steroid drops and observe.
Okay. Thank you. Thank you. So now we'll go into the deeper. So our next speaker is Dr. Samayek Mulkutkar. So he is a highly trained ophthalmologist and he is working now as a vitreoretinal surgeon and uveitis specialist at PD Hinduja Hospital, Mumbai. And he is actively participating in national and international academic various sessions. So he will be decoding the Vitritis for us. Over to you, Saman. Yeah, you are audible, but your voice is breaking. Yeah, we can see your slide also. Yeah, your voice is not clear, Samay. You can switch off the video and then try. If there is any, it is unstable. Sometimes it works.
Is it now?
Yeah, but we can hear one lag. Yeah, please go ahead.
Right.
Yeah.
So while we decode the vitritis clinical sign in from the perspective of the general ophthalmologist, we have to understand that when the patient walks in, his symptoms could be either a hazy view, or he's seeing floater, or he may have foggy vision or seeing through a glass. Symptoms may vary depending on the intensity of the haziness. So it may be slightly or a significant haze. Now, inflammation of the vitreous, vitritis, may be a major component of all posterior uveitis or intermediate. It may also spillover vitreous inflammation from the anterior chamber, as well as associated cyclitis. But we also have to remember that when a patient complains of a hazy vision, it might also be due to a vitreous hemorrhage, onset PVD, which is the common reason for a hazy vision. So vitritis is essentially a diagnosis. Now, while evaluating the slit lamp, on the slit lamp, when we focus beyond posterior lens margin, we may see vitreous cells. Are distinct cells which are non. They may be present in the anterior vitreous or may be present globally. In the may appear as distinct aggregates of vitreous which are, or may be also called snowbank, which is aggregate pars plana exudation mixed with the cells. Now these can be graded, and there are various ways to grade these vitreous cells. one of the ways which is adapted trial, which is depending on the calculating the number of vitreous cells, retrorental space, associated vitreous haze. This is the reading of vitreous haze, which was published in ophthalmology in 1985, and it depends on the clarity of this, the optic disc, and the associated retinal vessels. So it can be given as 0 plus, plus 2 plus, plus, and 4 plus, depending on the severity. And it is said that the vitreous haze by this method is slightly better than grading the vitreous cells individually. In the early stages of inflammation, or when there is a very minimum amount of inflammation, or if there is a choroidal inflammation primarily, then you may not find vitreous in the retrolental space. And you may have to do an OCT macula in the vitreous mode, where you will see the vitreous cells closer to the retinal surface, or overlying the inflamed lesion, or over the retinitis, or as a part of vasculitis. The differentials of vitritis can be both infective as well as non-infective. Endophthalmitis, whether it is exogenous or exogenous, is one of the more common reasons for vitreous or vitreous membranes. Other infections can be the spectrum of intraocular tuberculosis. I will go into the details. Syphilis and causes of as well. In the non-infective causes, we have Vasculitis, sarcoidosis, Behçet's disease. Fuchs uveitis. Now, Fuchs uveitis, we exactly don't see vitritis, but vitreous membrane with clumps of vitreous cells. Now, what is the significance if you see vitritis? We have to correlate the vitritis with the anatomic site of the inflammation. So, is the vitreous the primary site of inflammation, as in intermediate uveitis? Is it a bystander, or is it a spillover? It prompts a detailed evaluation. For example, a fluorescence, and we have to do a pattern recognition and see whether it is with just. Let's take a few examples. For example, full spots and superficial retinal hemorrhages. So the most common reason why a general ophthalmologist may see in this OP is to hypertensive retinopathy or diabetic retinopathy, retinal vein occlusion. Are associated, then the diagnosis almost change to sinusitis or an inflammatory. So the of vitritis will make a difference the way you see the pattern. If you see superficial cotton wool spots and associated hypopyon or oral and may well be a reason to diagnose a Behçet's disease. So, for example, cotton wool spots, retinal hemorrhages be seen in the common diagnosis of hypertensive and diabetic retinopathy, and with which they may have an entirely different differential diagnosis. Similarly, bilateral macular edema be a cause of uveitis, some presence of vitreous cells in an. So a diabetic or a retinal occlusion or any other non-inflammatory cause can also cause macular edema. Will point towards a uveitic or an inflammatory pathology. Similarly, without vitritis, whether it is unilateral or bilateral, can have a number of causes, like a non-atrophic ischemic optic neuropathy, hypertensive or diabetic, or other causes. And with vitritis, it is inflammatory edema. Last but not the least, vitritis without any reason, even after workup, if it not specific inflammatory markers, and in extremes of age, as has been highlighted by my previous colleagues, to masquerades. For example, this was a young male, 42-year-old, middle age rather, and has sheets of loose, no snowball, choroiditis, just a sheet of vitreous cells. prompted a diagnostic PPV and the diagnosis of lymphoma. Key take: vitritis guides the entire patient. It is almost always associated with uveitis. It can never be ignored. The red flags have to correlate vitritis with the clinical signs. Angiography is again a very important thing, and vitritis may be an early which are to manifest.
Thank you, Samak, for a wonderful talk. I would like to invite Dr. Ramandeep Singh and Dr. Somya Basu for the discussion. Well, Dr. Ramandeep, how would you differentiate between vitritis and vitreous hemorrhage? Because sometimes, old vitreous hemorrhage, dehemoglobinized blood may be confusing.
Yeah, thank you so much for a wonderful talk. So my answer is very straightforward. You just don't have to rely only on vitritis. Look at the other clinical signs also. And if you are seeing in the eye, which is non-trauma, non-surgical, you see synechiae, you see anterior segment cells, think on line of the vitritis. And the vitritis, normally, apart from the color, it doesn't form so dense sheets. Vitritis, we see snowballs and snow banking, but you will not see the sheets like vitreous hemorrhage, the gray vitreous hemorrhage through which the media cannot be seen. So I think these are the two things which is important: the clinical signs and the formation of sheets there, actually.
Dr. Basu, is there any way to differentiate between vitritis and endophthalmitis and vitritis and inflammation? Can you give us some tips?
So, the answer to this question is thank you, Rohit, and wonderful talk, Samya. So the answer to this question is very similar to what Dr. Ramandeep mentioned. You look at the associated clinical signs. You look at the lid edema, the conjunctival congestion, pain, all those signs of endophthalmitis. And of course, if it's an exogenous endophthalmitis, then for the trauma or the surgery, which will all be giveaways. Other than that, one thing that distinguishes endophthalmitis from the vitritis of uveitis or endogenous uveitis is the yellow glow. So if you see a yellow glow when you're looking at the fundus, then you should suspect endophthalmitis rather than the endogenous uveitis causing vitritis. Rohit, can I add a point?
Yeah, please.
To what Samyak mentioned, this is about the concept of spillover vitritis. And I also carried the same idea that vitritis spills over from the anterior segment, or the anterior segment spill over from the vitreous, either way. But this was pointed out by none other than Dr. Jabs himself, who, as you know, is the person who started the Sun classification system, that there is really no spillover. What we have is an iridocyclitis. So when you have an iridocyclitis, the iritis will cause the anterior segment inflammation and the cyclitis will cause the vitreous inflammation. And if we look at it in that sense, then we understand that, it's not that cells are moving between compartments, but, the cells are there de novo. You agree, Samir?
Yes, I agree. Yes.
Thank you, Dr. Basu. In the interest of time, I would like to invite our next speaker, Dr. Richa. She is a distinguished medical retina and uveitis specialist at Schroff Eye Center, and she's going to speak on exudative retinal detachment. Dr. Richa, over to you.
Good evening, everyone. Are my slides visible? Am I audible?
Yeah, Dr. Richa.
Okay, great. So, good evening. My name is Richa. I am going to be speaking on exudative retinal detachment as a clinical sign of uveitis. So, first, let's start off with a case. A 46-year-old patient with a history of headache and poor vision presented to our clinic. Her vision in the right eye was 6/60 and in the left eye was 6/96. Positive findings included presence of anterior vitreous phase cells and multiple pockets of SRF on fundus examination. So when a patient like this presents to our clinic, there are several questions that need to be asked before we can decode this clinical sign and come to a diagnosis and then further on plan the management of this patient. So if this patient walks in, what the first and most obvious question is it even exudative retinal detachment? So while differentiating exudative retinal detachment from tractional retinal detachment is fairly straightforward. In TRD, there are peak points of traction. There's an FVP, the RD is localized around the FVP. The retina is taut, it's concave. Differentiating from a rhegmatogenous retinal detachment can be tricky sometimes. So what are the clinical signs that we need to look out for to differentiate between the two? First and foremost, the most important clinical sign in exudative RD is, of course, shifting fluid. It is, however, not pathognomonic for exudative RD. RRD can also demonstrate shifting fluid in cases of bullous RD secondary to small holes, macular holes, in the absence of PVR, of course. So what are the signs that can more reliably differentiate rhegmatogenous retinal detachment from exudative? First and foremost, of course, a rhegma. If a break is present, then that is rhegmatogenous retinal detachment. And another important marker is that there are corrugations present on the surface of a rhegmatogenous retinal detachment, and exudative RD tends to be smooth. Also, there is something called a Schaefer sign or tobacco dusting that can be seen in cases of rhegmatogenous retinal detachment. So let's go back to our case. So is it exudative retinal detachment? The surface is not corrugated. It is smooth. No break was localized. There are cells, no pigments in the AVF. There was no Schaefer sign. The verdict is yes, this is exudative retinal detachment. So the next step is to establish the cause of the exudative retinal detachment. Right. So this is a non-exhaustive list of possible causes of exudative retinal detachment. Broadly speaking, there are three categories: inflammatory or uveitic, neoplastic, and miscellaneous. But there are a couple of considerations. Of course, the list of causes of exudative retinal detachment is vast. But when we look for key clinical features, the possibilities narrow down and we are able to focus on some more pertinent causes of exudative retinal detachment. The first key clinical finding to look out for is the presence of any mass lesion. Mass lesions associated with exudative retinal detachment may be infective, such as in choroidal tuberculomas, or can be neoplastic, such as in melanomas, metastasis, or hemangiomas. So this is the case of a 28-year-old who's presented with blurring and pain in the right eye. This is the fundus picture. The color of the lesion was yellow-orangish, which is not so obvious in this pseudocolor image. It was there were vitreous cells present, and we can see on the ultrasound again there is a low to moderate echogenic RCS thickening, associated retinal detachment next to it, and the OCT is also demonstrating SRF under the macula. So this was the choroidal tuberculoma, and further on, if you can take an OCT scan over the tuberculomas, you can demonstrate something called the contact sign. So contact sign basically is hyperreflectivity of the outer retinal layers on OCT, where the choroidal tuberculoma is in contact with the RP, and this is due to inflammation of the contiguous retinal layers. And because this is probably because the tuberculomas are more shallowly placed than sarcoid granulomas. Besides ocular investigations, systemic investigations such as MAN2, IGRA or quantiferon TB Gold, and chest imaging, preferably CT chest, are required to confirm that this is indeed a tuberculoma. Moving on, there is a subretinal mass lesion here as well, but it is dome-shaped, it is brown in color, it is well circumscribed, and there is associated exudative RD again. On ultrasound B scan, we can make out again a dome-shaped or a mushroom-shaped or a collar stud lesion with draping of retina and associated subretinal fluid around it. There are more typical features on ultrasound, such as acoustic hollowing, which is basically a sort of hypoechogenicity of the melanoma base, and this is also noted as the steep angle kappa on the A scan. This is a case of a choroidal melanoma. So when we talk about exudative RD with mass lesions, so the demographics of the patient matter. Like everybody has before me has also reiterated the extremes of age. You must, keep your antenna up for neoplastic lesions. Further, there is a further characterization that depends on the clinical features of the mass lesion. For example, is it dome-shaped? Is it brown like in melanoma? Is it orange-colored and without any inflammation, as in hemangiomas? Ocular investigations, especially non-invasive investigations like ultrasound and EDI OCT, are extremely helpful. So neoplastic mass lesions usually have a characteristic ultrasound finding which can help in clinching the diagnosis. Moving on, exudative RDs can also be associated with choroidal retinal inflammations, retinal vascular abnormalities. So certain choroiditis patterns such as SLC, serpiginous-like choroiditis, or APM PPV can have overlying SRF. Retinitis like Behçet's can also be occasionally associated with RD. Acute retinal necrosis can occasionally have exudative RD, although rheumatogenic RD is more common with ARN. There can be patients with vascular abnormalities with dilated telangiectatic vessels, which may leak fluid into the subretinal space, for example, in coats in FEVR. So this patient, for example, presented with this fundus picture in both eyes. There are areas of exudative retinal detachment marked out with the black arrows. There are areas of the transient retinitis, white spots marked out with the blue arrows. There's a sclerosed vessel. The FFA showed a characteristic ferning pattern. On specific questioning, he admitted to a history of recurrent oral and genital ulcers. He was HLA-B51 positive. However, it is not essential for a diagnosis of Behçet's. But here, this is the diagnosis. This patient does have Behçet's. Another case of exudative retinal detachment with vascular abnormalities. So this is the fundus photo of a 6-year-old boy with unilateral findings of vascular telangiectasias marked out by the red arrow, subretinal cholesterol, and exudative retinal detachment. This is a classic case of coats. This FFA can confirm the telangiectatic vessels. So in cases of this group, the exudative retinal detachment with additional retinal, choroidal, and vascular findings is a heterogeneous group of entities. In most of these cases, the exudative retinal detachment is not the defining or definitive feature of the disease. It may, in fact, be a red herring. It might obscure the more important clinical signs. So here we have to, do a very careful and thorough ophthalmic checkup. And the final group of exudative RD, which is defined by an absence of associated mass lesion and an absence of retinal, choroidal, or vascular abnormalities. This group can be further divided by the presence and absence of AVF cells. So if there are AVF cells present, there are 3 possible uveitic differentials: VKH or Vogt-Koyanagi-Harada disease, symptomatic ophthalmia, or posterior scleritis. And in the absence of AVF cells, CSR and UES are possible differentials. So this case is again to illustrate, this group of exudative retinal detachment. This is a 34-year-old female patient who presented with pain in her eye with mild blurring of vision. On specific questioning, she did say that the pain was more on moving the eye. On examination, there's temporal episcleral congestion. There is a classical T sign on ultrasound B scan with a small chink of SRF on OCT. So this is a case of posterior scleritis. Now, finally, if there are no AVF cells, only pockets of SRF without fibrin, this is likely to be CSR. A pinpoint or a smokestack leak on FFA without a disc leak can help confirm the diagnosis. So in this group of patients where exudative RD is present without any typifying features, the exudative RD is the main or the defining clinical feature. It is important to look closely for subtle signs of inflammation. Pain may be a common complaint in these uveitic conditions. It may even precede this SRF. For example, headache in VKH or pain on ocular movements with minimal SRF in posterior scleritis, which may be missed unless specifically checked for. So I'd like to reiterate that pain is an important symptom, and it is important to not dismiss this complaint, which can be a slight tendency, especially in a busy clinic. So, and a close watch for subtle signs of inflammation and developing exudative RD is important. Finally, going back to our original case, which of these broad categories does our patient fall into? We have established at this point that yes, this is exudative retinal detachment. And 2, there are no associated mass lesions. There is no retinal, choroidal, or retinal vascular abnormalities that we can make out. There were cells in the anterior vitreous face. There was history of headache preceding the drop in vision. There was no history of any ocular trauma or ocular surgery. So we are probably dealing with VKH. That is the provisional diagnosis. The other eye also shows a similar picture. And when we look at the swept source OCT, it shows many of the important biomarkers of VKH. The blue arrows demonstrating the vitreous cells, the elevated disc, the subretinal fluid marked out by the yellow arrows, the ballard or the bacillary layer detachment marked out by the green arrow, RP undulations because of the gross choroidal thickening, the choriocapillaris compression. So all of these findings again are, kind of confirming our diagnosis of VKH. The FFA is showing some pinpoint leaks and filling of the SRF pockets with dye. There is a disc leak. So our diagnosis is firmly VKH. We started her on IVMP. There was a dramatic reduction in the SRF. And later on, we are going to be starting her off on immunosuppressive therapy as well. So what is the take-home message here? I wanted to just highlight one point from each group of exudative RD cases. The first and foremost is that pain is an important symptom. Do not dismiss the complaint of pain. Look for subtle signs of inflammation and keep a close watch for development of exudative RD. Exudative RD can also be a red herring in cases of choroiditis, retinitis, and other retinal vascular abnormalities. It may not be the main, the MVP, so to say, the main, the most valuable player in that setting. And your plastic mass lesions usually have characteristic ultrasound findings, which can help to clinch the diagnosis. Thank you. I'd like to thank Partho sir and AIOS for this opportunity. Thank you.
Thanks, Richa. That was a wonderful presentation. So I would like to bring the teachers of the teachers, Professor Jyotirmoy Biswas and Dr. Ramandeep Singh. So I just want to ask two questions to you. I'll combine that and I'll come to one by one. So first I'll come to JB sir. So do you advocate FFA in all cases of exudative retinal detachment? And what is the first line treatment modality in managing a case of exudative RD? JB sir. Can you unmute, sir?
That's not all cases, but majority of the cases I try to do the FFA because the bullous RD can be due to the CSR also, multiple leak CSR also. And even if you bullous RD, you can get that leak of the CSR. But if it's the obvious bullous RD, then big bullous RD, I don't get that. You don't get good FFA pictures for that. So it's not mandatory to do all cases to be exudative RD to do the fluorescent angiogram. I do that. Ultrasound is my first tool in case of bullous retinal detachment.
So, and what is your first line modality in when you manage? You prefer pulse corticosteroid or IV methylprednisolone, or you use the oral steroid?
I do pulse IV methylprednisolone for the last 10-15 years. When we started getting the IV methylprednisolone, all bullous RD due to the inflammatory origin and non-infective, I treated with the pulse steroid, IV methylprednisolone. Is my first line of treatment. 3 days, 1 gram daily for 3 consecutive days for the adult.
Do you advocate using dexamethasone, because many places they don't use IVMP and I have seen that they administered the patient in
dexamethasone is a short-lived. You can give that one when there is no IV methylprednisolone available, but it's a short duration of treatment.
Professor Ramandeep, what is your first line management? And first, do you do FFA in all cases of exudative RD?
Like Dr. JB said, because I believe this is a very very diverse one. So you can have a localized exudative RD, you can have an exudative RD going to the aura. So you have to, define that what is happening there. Is it some inflammation there, or is it some new plastic condition? Is it drug induced? I have so many things to do. But yes, like sir said, most of the time I end up doing FFA and sometimes ISG also, where the bullous RD is not there. Where if I see any part of the retina, I'll try to run the Swift sort OCT also through it. And because the etiologies are very, very diverse. And yes, the IV methylprednisolone, because sitting in a tertiary center, I have the advantage of admitting these patients. I can admit them, I can get their PET scan, I can get their MRI. So I will not like to give a pulse steroids to a patient who does not require it. So this is how I'll go about. Yeah.
Point well taken. So the idea is that if you see a exudative RD, you have to rule out the various other causes, and you need to investigate this patient to rule out the CSR sometimes, which can present as bullous RD also, and the treatment is paradoxical because without ruling out CSR, if you can administer steroid in any form, it can be paradoxical. So we in last 1 hour we have decoded the 4 clinical signs of uveitis. So next we have the retinal vasculitis, and we have Dr. Anup Kelgaonkar to decode this clinical sign. So just tell about Dr. Anup. He is a faculty member and young dynamic vitreoretinal surgeon and uvea specialist who is working at LV Prasad Eye Institute, Bhubaneswar. Over to you, Anup.
Thank you, sir, for a wonderful invitation and the introduction. Thanks, AIOS as well. And Partho sir has given me a very difficult job of covering retinal vasculitis in 8 minutes alone, and it's such a huge topic. I'll try to make some orientation to that. So I will deal it with 2 scenarios. One scenario, retinal vasculitis has a lot of friends in the eye, and the other scenarios, they have no to less friends in the eye. One friend that you will see very commonly with retinal vasculitis is retinitis, and another friend is choroiditis. These 2 topics will be covered by my other friends later after this presentation. So let's dive deeper into various this retinitis with retinal vasculitis. One of the very commonly seen things is toxoplasma retinitis, and you will get a toxo lesion somewhere. Here it's near the disc, it is here it is nasally, but the retinal vasculitis will be almost everywhere. And the retinal vasculitis is not very prominent or not very infiltrative or exudative, if I may say so, as compared to TB or sarcoid. It's very subtle, and it can be seen in quadrants way away from the toxoplasma retinitis as well. So toxoplasma retinitis can have this periphlebitis, but also it can have arthritis, and which is Kyrle's arthritis. There would be such crystals seen especially when the retinitis is resolving. So initially this picture you see a active lesion near a scar, but as the scar is trying to heal, we see this Kyrle's arthritis. Most of the times they don't take stain on angiography, and they're generally not considered a sign of activity. So we go on to the third type. This I've just named it as Kyrle's-like because in toxoplasma retinitis, as I was saying you earlier, you'll get a retinitis somewhere else. The other parts of the retina might have the small pre-retinal precipitates, and they might be, some of them might be on the vein or an artery simulating a Kyrle's-like, and they can be also on the isolated on the various parts of the retina. So these are 3 or 4 patterns that are seen in tox. Now we have a very nice, again, an infection here where old scar is seen, where we have a focal retinitis, and there is vasculitis everywhere. Now, okay, but probably we are dealing with retinitis. I did an angiography to confirm that hypo pattern surrounded by hypo. But the retinitis looked too whitish to me, and it was too globular and roundish subretinal clinically. Got an OCT. This was predominantly subretinal with a kind of rain cloud sign. Thought it to be fungal. Took a deeper biopsy from this area, taking the cutter just over the deeper parts of the vitreous over the retina, and we got it positive for candida and treated likewise. So the point to take here is endogenous endophthalmitis, especially the focal ones, can have such retinal vasculitis as well. Sometimes routine retinal endophthalmitis post-surgical can also have a few areas of retinal vasculitis. So this is a picture to remember. The focal retinitis with a scar near might not always be a toxo, and OCT is many times very helpful in such cases. Now we come to another type of infection now. She was a 16-year-old female and on chemotherapy. And you get to see here that many places there is skip vasculitis in the mid periphery, and you have a focal lesion, which is kind of a granular heterogeneous mid peripheral region, which is an isolated retinitis. say in the center with multiple satellite lesions. This is kind of an early presentation of a viral retinitis. Many times after this mid-peripheral spreads, this disease go on to form either an ARN or a CMV retinitis like picture depending upon what we are seeing. So very important to see that viral retinitis can have periphlebitis also and arthritis also. So both the things are possible when we are dealing with viral infections. This is what I was still referring to earlier. CMV retinitis can have various patterns. This is a mixed pattern. You have a fulminant retinitis here, some granular retinitis in this part, and you have frosted branch angiitis, something like an ice on the frosted branches of the tree. So these are various patterns that you can see in the various infections, and the friend of retinal vasculitis, the retinitis, often is the clue, the morphology of the same. Now, we get these cases very rarely, especially in the winters when the season of flu is there, and sometimes sporadically in the other seasons. You call it by various names. This particular patient was having these cotton wool spot-like retinitis, neuroretinitis like picture, macular star, some disc involvement, and you can see this artery having some periarterial exudates kind of thing. And few people label it as posterior retinitis. Someone will like to call it as posterior vasculitis or epidemic retinitis, as Dr. Ankush Kawale will say it to be. And we can get vascular involvement in these particular cases as well. But again, as these cases also have retinitis and neuroretinitis in the background picture, making the diagnosis much more easier. And then let's come on to one of the favorite diseases of ours, tuberculosis, which is so common. And this is one kind of retinal vasculitis that you will always see very commonly in the OPDs. And there are three features that one needs to look at: focal lesions, which are subvascular. It might be an active lesion like this one, which is different from the retinal vasculitis. So this is retinal vasculitis, and these are pretty bigger. And when they heal with pigmented subvascular scars. Then the second sign that you have is focal vascular tortuosity. You see this tortuousness of the vessel. Sometimes it is broad, sometimes just focally. And the third thing is it is an occlusive retinal vasculitis. So if in a TB endemic country, you are seeing these particular three signs, then you are possibly looking at etiologically a tubercular retinal vasculitis. And it's very important that we give anti-tubercular therapy subsequently to them. Now, there are a few caveats in the occlusive retinal vasculitis. This one is a picture that we saw. Now, this one is also occlusive retinal vasculitis, but there is a difference. This is because of tuberculosis, while this is because of syphilis. So we have to carefully look at these small miliary lesions and a small placoidea, and these clinical features are many times a big clue. Another thing that we look is occlusive retinal vasculitis. A lot of occlusion can be left behind, leading to widespread capillary non-perfusion areas, which can lead to new vascularizations, vitreous hemorrhage, fractional detachments, combined detachments. Sometimes a persistent and a refractory CME could also be seen in occlusive retinal vasculitis. Now let's come to the second scenario, the retinal vasculitis, which is sometimes seen, sometimes not seen. And remember, when we have cells around the retinal vasculitis, we see the retinal vasculitis. If the retinal vasculitis is because of immune complex depositions or immune-mediated diseases, that we might be seeing just no perivascular infiltrates. Or systemic vasculitis can have some vasculopathies. So let's dive into. So this patient was a granulomatous anterior uveitis, corneal involvement, KPs. So we have seen recently in earlier presentation, viral keratouveitis. But you see posteriorly, there are a lot of occlusions that we saw in this patient and a lot of capillary non-perfusion areas, which is referred to as non-necrotizing herpetic vasculitis. So in a case of anterior viral uveitis, look into the back of the eye for two things. One is ARN or a non-necrotizing herpetic vasculitis or a retinitis. Sometimes the retinal vasculitis is seen, sometimes not. That was what I was referring to. Behçet, sometimes you can see a retinitis with retinal vasculitis. Sometimes it is only in a form of a ferning, which is subclinical. You get it on an angiography. So Behçet's can have a fern pattern, not pathognomic. It can have both artery and vein involvement. It can involve the smaller as well as a larger retinal vessels. This is kind of a specialty of Behçet's. And they might have sometimes a perivascular infiltration as the right top diagram shows, or sometimes just a subclinical phoning. Retinal vein occlusions is sometimes a possibility with Behçet's patients. We come on to vasculopathies that I was referring to. This patient has a ischemic optic neuropathy, small arterial occlusion, inferior branch retinal retinal arterial occlusion. We come to the other eye, we see not much, but when we do an angiography, lot of aneurysm signifying a lot of ischemia is there. So this was a case of Takayasu's arthritis. So where we could get a Takayasu arthritis type 2, and the vasculitis happening in the large vessels of the aorta. What we have in the eye is kind of an ischemia or a vasculopathy that can be said. So we take help of our cardiology, rheumatology colleagues. Another women, CRVO like picture, but you see some vasculitis here, very poor vision, lot of hemorrhages. And when we got an angiography, there's hardly any perfusion, just a perfusion till 1 or 2 disc diameters around the disc. And when tested, this was a lady with a APLA, antiphospholipid antibody syndrome. You send it for various tests. So we have to be very careful when there is a vasculopathy, vasculitis overlap with very poor perfusion, generally SLE, APLA, Takayasu group of diseases, this case could be. We have another case, lot of retinal ischemia. We have PAM lesions and empty arteries, empty veins at places. We did an angiography, huge neovascularization, and hardly any perfusion beyond the disc. This was a 36-year-old female. We checked her hands, her face, and she had such rashes. And this was a case of SLE that I was earlier referring to. Now let's come to the miscellaneous things. There were just a few more ones. And this was a case where you see skip vasculitis and there is a subvascular scar. Is it because of tuberculosis? Sometimes. Now we have to rule out this particular disease entity, syphilis, which can mimic almost anything. And here it is amazingly mimicking a subvascular pigmented scar. So we have to be very careful, and TPHA should be in the panel of our retinal vasculitis evaluation. Now, this is, why retinal surgeries, this was a surprise. So retinal vasculitis sometimes can be surprise. There was a trauma, vitreous hemorrhage. You see small iron foreign body here, and we got a foreign body out, and you see the oil there, retina attached. And on the weak one, there is a retinal vasculitis that you can see here with some hemorrhages. So hemorrhagic retinal vasculitis status post-trauma. And this comes as surprise at times, at sometimes differential. I don't know what this particular is. It's up to the panel today. But hemorrhagic retinal vasculitis after trauma is sometimes seen. Sometimes it could be because of endogenous endophthalmitis, and sometimes very rarely a silicone oil reaction. Now, other miscellaneous, this was a case of hemorrhagic occlusive retinal vasculitis. You see the inner retinal ischemia on the OCT, and you see the small, almost occluded both retinal veins and arteries. Seen many times after intraocular antibiotics, especially vancomycin, amikacin, are associated with this particular hemorrhagic occlusive retinal vasculitis. We saw this in a case of focal endogenous endophthalmitis. Unfortunately, it's very difficult to treat this particular group of retinal vasculitis cases. And almost last but not the least, this is a very idiopathic, as the name suggests, entity and differentiated. We don't know why it causes. It looks much like, in quotes, you will get a yellowish accumulate of hard exudates in the center. Similarly, in this IR1, we get hard exudate clump in the center. And when we have a closer look, we have along the arteries, aneurysms along the arteries. And you have other features like neuroretinitis. We have retinal vasculitis. And one of the most important is we have peripheral retinal ischemia or neovascularizations, which might need a laser. So summarizing, retinal vasculitis can be either artery, vein, or both. They have a lot of friends, associations, as I can say so. Retinitis, choroiditis, and a disc involvement. Occlusive vasculitis is a disease spectrum in itself, so you have to be careful about first the diagnosis part of it, and then during the management, we saw FFA guided laser could be something that you should consider in those, and various etiologies that ocular vasculitis can be because of. And last but not the least, systemic vasculitis may or might not have retinal vasculitis which are visible. Say, for example, Behçet's is a systemic vasculitis as well as the retinal vasculitis. On the contrary, others like Takayasu, the vasculitis might be in the larger vessels, what we get in the eye is vasculopathies. And three diseases that we have to be very careful about, which have a lot of retinal non-perfusion, is SLE, Takayasu, APLA. And we have to be very careful because they are sometimes life-threatening diseases, and making the diagnosis could save the life of the patient. So thank you. Thanks.
Thanks, Anup. Wonderful collection of cases. Amazing, amazing. I would like to invite Dr. JB sir and Dr. Somyawa Basu for the discussion. Basu sir, do you believe in existence of Eels disease, or is it basically tuberculous uveitis? So you're mute.
Yeah, so Rohit, you put me in a difficult situation to answer this question. Sir is smiling. My understanding is that nothing is really idiopathic at all. And there was a very nice editorial in JAMA Ophthalmology some years ago by Professor Rosenbaum that, how we need to move away from the term idiopathic. And the idea of not really falling in line for Eels disease is very much similar, that everything happens for a reason. And if we label something as Eels disease, we generally tend to ignore the reason which may present itself not just during the initial presentation, but also at a later stage. So what I want to emphasize here is that Eels disease is not just about whether it is TB or not TB. That's a separate story. But it could be any other retinal vasculitis as well, especially any other occlusive retinal vasculitis. And we should not be missing on those diagnoses. We saw pictures of Behçet's which could look exactly like eels. And if we label it eels start at the beginning itself, and we miss the genital or the oral ulcers, we may be missing out on the diagnosis. There is what I feel.
Thank you, sir. JB sir, how do you manage cases of recurrent vasculitis?
So I would like to answer the first questions a little bit, because is that eels disease, when it started with that one, it was eels didn't thought that it's a vasculitis. It thought there is a constipation epistax. Later on, Wadsworth thought that found that is a retinal vasculitis. And those days, the investigations were limited chest X-ray and Mantoux test that was done. But when we did that molecular biologic test, as well as the quantiferon TB gold test, high resolution CT chest, as well as when we have got chance to look into the tissue of the eye molecular biologic study, the phenotype of the Eels disease, that young adults, vasculitis, going to the capillary non-perforation, neovascularization, vitreous hemorrhage, this group of patients found to have MTB DNA in their vitreous epiretinal membrane, as well as ocular tissues, intraocular tissues, indicating that this term should be really avoided and can be called as a tubercular retinal vasculitis, because the etiology is the MTB DNA, which is an immune-mediated process, not the active bacilli, but that immune-mediated reaction to the MTB DNA. And your question, second question, can you repeat?
How to manage cases of recurrent vasculitis?
So I start with that patient's record seeing, and then going through the history, and then history like oral genital ulceration, exposure to the TV, and any previous investigations of Mantoux, quantiferon, HRCT chest or chest X-ray. And I try to rule out other diseases, as Vasu has told. There is a lot of times is that we miss, like SLE, collagen vascular disease, Behçet's disease, sarcoidosis. So I try to examine him and narrow down my findings and then order a tailored laboratory investigation to rule out other causes of retinal vasculitis. So my workup would be syphilis, TB, sarcoid, and collagen vascular disease. At least basic workup will be done in this case. And I don't mind to go and do a second time testing as the disease course changes. So some of the basic workup in our country, you should do that TB and sarcoid as well as the syphilis to rule out an anti-nuclear, anti-double stranded anti-nuclear antibody, antiphospholipid antibody. But this is narrowed down based on the history and clinical examination. So I don't do all the tests in all patients.
Thank you, sir. Next, I would like to invite Dr. Sharanya Abraham. She is a consultant at Shankar Nethralaya, and she's going to present on choroiditis. Dr. Sharanya.
Thank you. At the outset, I would like to thank AIOS for allowing me to talk on this topic, choroiditis. Are my slides seen?
Yeah.
So in the beginning, we must know that any fundus lesion that we're looking at, is it retinitis, is it choroiditis, or is it retinochoroiditis? Now, to differentiate, the main thing that we need to know is the relation of the retinal blood vessel to the lesion. So fundamentally, if the retinal blood vessel is not seen, it is a retinitis lesion. If it is clearly seen, it is choroiditis. And if it is partially seen, then think about retinochoroiditis. The next thing we look at is the pattern of the lesion. It could be a focal lesion or a solitary lesion. It could be multifocal, or it could be disseminated, as in choroidal nodules seen typically in tuberculosis and sarcoidosis. Again, focal choroiditis is of two types. You have the macular and extramacular forms. A word about retinochoroiditis, especially if it is focal with an overlying vitreous haze, think toxoretinochoroiditis. Here you can see the active lesion with overlying vitritis and the Chilaris arterolitis that was described by the previous speaker. Based on the activity of the lesion, you have here GHPC or serpiginous choroiditis, where you have a hyperemic disc and a lesion extending to the fovea. The center starts scarring initially in this lesion, followed by the border. So the border remains active, and with scarring, the entire lesion becomes flattened. The healing pattern in toxoplasmosis is a little different, where you have peripheral scarring and the center is still active. So what investigations do we do in a patient who's diagnosed to have choroiditis? TB and sarcoid must be ruled out. These are a few of the tests that we can do. Toxoplasma, if it is a suspected retinochoroidal lesion, and syphilis. These are a few ancillary investigations that we done, where warranted PCR analysis of the aqueous and vitreous must be done to rule out infectious etiologies. A color fundus photograph is a very basic thing that has to be done to document any patient with choroiditis, preferably a montage to look at the peripheries. Wide field imaging is also done. So you can see a posterior pole photograph and a wide field photograph, and you see that the extent of the disease is much more as is seen on the wide field photo. Fundus autofluorescence is extremely important in choroidal lesions because, as marked with the blue arrow, there is a border of hypoautofluorescence seen around the hyperautofluorescent active edge. Now, this actually indicates an edema in the deeper retina and the RPE. So the pattern of healing that we typically describe in choroiditis is an early hyper with a late hypo. So with in a fundus fluorescein angiogram or even in an autofluorescence, you find that the lesion becomes more and more hypoautofluorescent, including the hyperautofluorescent border. Now, why this happens progressively is because there is a loss of fluorophores, and therefore there is a marked hypoautofluorescence. Coming to fundus fluorescein angiography, here you see that there is an early hypo. This is due to hypoperfusion of the choriocapillaris and blockage of fluorescein due to edema. In the mid phase, you have hyperfluorescence, which is because of the leakage from choriocapillaries at the border of the inflamed lesion. In the late phase, you find that there is a more diffuse leakage. This is from the larger choroidal vessels. The opposite is true in an indocyanine green angiography, where there is a progressive hypercyanescence. A wide field, ultra wide field FFA has also been described in this paper, especially where a patient with a rather posterior pole lesions was treated with antitubercular treatment, and after 8 weeks, as is seen in the bottom pictures marked with the white arrows, you find that there are newer lesions outside of this region. So this is important in the setting of paradoxical worsening, which we will deal with a little later. Now, an OCT essentially is an in vivo quasi-histological image. So conditions in which an OCT might be really applicable are multifocal choroiditis or anything that involves the macula, where there is a suspicion of CNVM development. The patient might present with a quiet eye and a recent onset reduction in vision. So SSOCT can be used, OCT angiography. These are some representational images from the article by Ivanici et al., which shows us in placoid syphilitic chorioretinopathy, typically you find a diffuse disruption of the outer retinal layers. In multifocal choroiditis that we see very commonly, there are these hyperreflective lesions that break through the retinal pigment epithelium into the outer retina. And in APM-PPE, this is a composite fundus photograph, ICG and OCTA, in an acute stage, which shows choroidal hypoperfusion, which is classic of this disease. And it shows that the area, the extent on ICG is a perfect overlap as that on the OCTA. So in a choroidal granuloma on ICG and OCT, it is seen as small hyporeflective lesions. Now, these lesions have to be differentiated from large choroidal vessels, and that is by the blocked transmission beneath a choroidal granuloma. The bottom picture is of a larger choroidal granuloma to differentiate it from a toxoplasmic chorioretinitis. In a toxoplasmic chorioretinitis, always look at the disorganized retina that overlies the lesion. The overlying retina is relatively maintained in a choroidal granuloma, except for maybe a little bit of subretinal fluid. This is a patient with PIC or punctate inner choroidopathy. So it looks relatively quiet, but multimodal imaging shows that the FFA and the SSOCTA correspond. There are areas of CNP and new vessels. Newer modalities that can be mentioned are something called adaptive optics and microperimetry. This is mainly in patients with multifocal choroiditis and PIC, where there is a reorganization of cone photoreceptors and decreased areas of disruption with treatment that have been documented. So when we come to treatment, the first thing is we must know whether these are infectious or non-infectious entities, treat accordingly, definitely with oral steroid or immunosuppressant, and appropriate antimicrobial therapy. So the management broadly would depend upon the location of the lesion, the pattern of the lesion, and the level of activity at presentation. So if you have a macular-threatening non-infectious lesion, definitely intravenous methylprednisolone for 3 days, 1 gram, followed by a course of oral steroid with or without immunosuppressives. So the commonly used immunosuppressives that we use are azathioprine, methotrexate, and mycophenolate mofetil. It can be used either as single agents or in combination. Sometimes intravitreal steroids may be given, anti-VEGFs may be given when there is a CNVM. In relentless placoid chorioretinitis, adalimumab may be tried. Always refer appropriately to an infectious disease specialist if any infectious cause is identified. So the recommendations for ATT are essentially 4-drug ATT for the first 2 months, followed by 2-drug ATT for a minimum of 18 weeks. These same principles of treatment about ATT are also applicable to HIV-infected patients. So when we are treating patients with oral steroids and ATT, this is an entity that we must really look out for. This is known as a paradoxical worsening, where the lesions that were initially responding well have a reactivation, or you have a new lesion in a new site. So while on ATT, it could be either a clinical worsening or a radiological worsening, and the hypotheses include either a reconstitution of the immune response or an elevation of tumor necrosis factor level in the mycobacterial cell wall. How do you monitor a patient with choroiditis? Essentially, anything that threatens the macula, give them an Amsler grid and teach them to monitor. Fundus photograph and autofluorescence at all visits. So when we talk about choroiditis, we must also know what is not choroiditis. As we said, any yellow creamy lesion in the fundus is not choroiditis. So we have this patient, if we do one investigation for him and we do an FFA, we find that he does in fact have multiple leak CSR. So we will not put him on any kind of steroid. This patient with a lot of scarring in the periphery is not a multifocal choroiditis, and intraocular sampling shows that he does in fact have intraocular lymphoma. So this patient here has a little bit of a disc hyperemia, has some ILM folds and a lesion which is inferotemporal to the fovea. Again, in this patient, he resolved completely with steroid. If there is one investigation you will do for this patient, let it be an ultrasound which shows a widening of the subtenon space or the T sign. This patient has a posterior scleritis. So in conclusion, a high level of clinical suspicion along with appropriate ancillary testing and a prompt initiation of treatment with periodic follow-up due to the nature of recurrent disease must be done for the best visual outcomes in patients with suspected choroiditis. Thank you very much.
Thanks, Sharina. It was a nice talk. So before I bring my next two panelists, I'll request Dr. Samindra to upload the presentation. You get ready. I'll come back to you. Samindra, are you there?
Yes, Dr. Partho, thank you.
So let me call Dr. Basu and Dr. Ramandip Singh. So my two questions to you quickly. I'll come one by one. So my first question is, are all cases of choroiditis in India is due to tuberculosis? And second is, how do you manage recurrence of choroiditis that has occurred after 9 months of ATT? So first question is I'll repeat again, all cases of choroiditis due to TB? Professor Ramandip, please.
Yeah. It was a very nice and elaborative talk. So TB is still an enigma. And so is ocular TB. Ocular choroiditis is still a bigger enigma. The people like Dr. Basu, Dr. Biswas, and Dr. Kusum are, they are trying to take care of this enigma by immunological or microbiological method, but still we don't know. So what we know is, as the courts have beautifully said, that treating these lesions actually in a population like ours are beneficial. So I would say that till the time we have a definite Ramban Ilaj for TB, I think I will go with the clinical evidence. And yes, I don't know what it is actually. All right. But TB to anti-tubercular treatment is definitely working in these patients. To answer the second question, so you have already given ATT for the 6 or 9 months, and the disease is record. So like Dr. JV said, I would not be shy of getting the patient investigated again for the plethora of tests which are mimicking this lesion. And if I could get a biopsy from any tissue in the body or from the eye when the enough cellular reaction is there, I would like to get a PCR or some immunological test and probably look for the INH or rifampicin resistant, which is possible nowadays, and look for that. And if I am not able to find any of these, and my internist give me a go ahead and I can treat the patient with the immunosuppression, I will go ahead and treat this patient with the immunosuppression this time under a close watch. This will be my two answers actually.
Thank you. Dr. Basu?
Yeah, so Partho, all choroiditis is definitely not TB, but it's not an easy diagnosis to make, just like Dr. Ramandeep mentioned. Some of the signs that should tell you, now, unlike retinitis, which is almost always infectious, choroiditis, a lot of causes are non-infectious. But some of the signs which will tell you that you're dealing with an infectious choroiditis, which is much more likely to be tuberculosis, are number one, involvement of the retina. So I think we should be very careful when using the word chorioretinitis versus choroiditis. And if you see a bright spot in the middle of a dull lesion, then you know that you're dealing with a chorioretinitis. Now the retina has been involved, and that's a sign of infection. Second thing is, if you see that the margins of the lesions are irregular, as you see in a serpiginous-like choroiditis, you are again probably dealing with a infectious lesion. And third is, if you see other tissues getting involved, and one I said is the choroid moving into the retina, or if you find a choroid moving into the sclera. And how will you know that? The patient will complain of pain. A choroiditis patient typically does not have pain, but if the patient tells you that he or she has pain, and if you see a subtenous fluid, which need not be a T sign, on B scan, then you know that the sclera is also involved. And all of these are signs that you're dealing with a infectious choroiditis. On the other hand, if there are multifocal lesions and the lesions are very regular and very deep-seated, like you see in sarcoidosis, then you're likely dealing with a non-infectious choroiditis. So these would be my takeaways for this question. I think I'll leave the second question for the constraints of time. Thank you very much.
Thanks. Thank you. So it's my pleasure to introduce Dr. Samendra Karput, a distinguished faculty member at AIMS Bhopal. So he brings a wealth of experience from his time at Stanford University and holds prestigious fellowships from both the International Council of Ophthalmology and All India Collegium of Ophthalmology. So over to you, Samendra. You are muted.
Thank you, Dr. Partho, for the introduction. I thank AIOS USI and the esteemed panelists for taking out their time and this opportunity. So my topic has been a little difficult. I really had to sit down and get all the information together to be able to present this. We see it day in and day out, but to put it in a presentation was a task. So the optic nerve involvement is universally seen in almost all kinds of uveitis, which I've listed out here. Depending on the anatomical diagnosis of uveitis, like anterior, intermediate, posterior uveitis, and also based on the etiological diagnosis of uveitis, including infectious and non-infectious. Now, optic nerve head involvement in uveitis indicates, and it could also be understood under the following leads. It could be a primary involvement or a secondary involvement, which we have been routinely discussing as a spillover or an adjacent advancement of the inflammation. And it could also be seen clinically in a general walk-in OPD as a marker of disease severity and also to monitor response to therapy. It may act as a starting point for the direction of uveitis workup, and it can be a prognostic indicator in therapeutic, serve as a therapeutic guidance. So let us understand these points based on walk-in uveitic patient in your clinic. So I'll illustrate this based on few cases. So a 35-year-old female presents with bilateral blurry vision, nausea and headache, no significant systemic history, and there's no history of trauma. She was diagnosed as VKH disease. Now, so we can see that in FFA, there is a typical presentation of VKH with multifocal leaks, disc leak, and there was no doubt about the diagnosis as such. So the optic disc involvement in a case of VKH, it is a primary involvement in the disease process itself, which offers a significant diagnostic value. We can actually monitor the therapeutic response by tracking the peripapillary choroidal thickness on B scan, and also the presence of hyperfluorescence in early phase and leakage in the late phase of fluorescein angiogram. Increased subfoveal choroidal thickness in the fellow eye, it also acts as a marker of the subclinical disease, along with disc staining sometimes in the fellow eye where the clinical manifestation is not seen as yet. The management is standard corticosteroid therapy and immunosuppression, and the involvement of the optic disc can help us in monitoring the disease process and when to stop corticosteroid therapy, because the disc staining can sometimes last even after all the signs of clinical signs have disappeared. And the point to note here is that optic nerve head edema in VKH is due to the choriocapillaris and associated inflammation of the prelaminar portion of the optic nerve head. Now, moving on to my second case, it was a 50-year-old female with sudden floaters in the left eye. Systemic history was noted for HIV. Recent CD4 count was 46. Ocular exam, there was vision was normal in the right eye. Left eye had 20/25 vision. Anterior chamber, right eye was normal. Left eye had occasional cells. Rest was okay. PCR vitreous tap came out to be positive for CMV. Now, what happens in CMV? The optic nerve involvement can be classified as that of zone 1 disease that changes the prognosis. It can be immediately sight-threatening disease, which in zone 1, which will require prompt initiation of therapy. However, it also indicates poor prognosis compared to zone 2 and zone 3. Now, the prognostic and therapeutic value of optic nerve involvement in CMV retinitis is it is based on the involvement of the optic nerve head. So optic nerve head for one to start with shows that it is a zone 1 CMV retinitis, and management is routine with induction therapy by intravenous ganciclovir or oral valganciclovir, hard therapy, and intravitreal ganciclovir may be added for a faster response along with intravenous therapy. Now, optic nerve involvement from retinitis due to CMV are secondary to endotheliotropic properties of CMV. Case 3. A 29-year-old male presented with blurred vision and associated eye pain. There was a history of new kitten in the family 3 months prior. There was no other significant systemic history. The labs revealed IgM toxoplasma, it was higher, 160 international units, and IgG was 57, both were higher. We can see that there is a whitish lesion adjacent to the optic nerve head with surrounding edema. So this was a clear-cut case of toxoplasma neuroretinitis. Now, the optic nerve involvement in neuroretinitis, it is important to note that toxoplasma usually presents with retinochoroiditis. However, a case of neuroretinitis, toxoplasma should be one of our important DDs. The management in such cases is with double-strength sulfamethoxazole trimethoprim. Intravitreal clindamycin and dexamethasone may also benefit in such cases by achieving higher intravitreal drug levels and easy resolution. Now, as I said, that although a common cause of retinochoroiditis, toxoplasmosis should be considered as a leading differential in the infectious etiology of neuroretinitis as well. Case 4, a 33-year-old man presented with painless progressive vision loss in the left eye for 2 weeks. Systemic history was significant for shortness of breath for 6 months. Vision was 660 and there were diffuse multifocal keratic precipitates. The right eye was normal. We can see there is a small lesion next to the optic disc. In the left eye, there is a elevated lesion on B scan, and we can see the mutton fat KPs all over the endothelium in the picture. Now, this was a case of sarcoid uveitis, and optic disc involvement in this case is it presented as a choroidal sarcoid granuloma, which was compressing the optic nerve head. So here, the workup for TB was negative. AIOS was, however, very high. CT chest showed diffuse hilar lymphadenopathy, and the management was standard using oral prednisolone along with oral methotrexate. Sarcoid responds very well to oral steroids with methotrexate. So the optic nerve involvement in this case was directly due to the compressive effect of the sarcoid granuloma, and it responds very well to therapy provided it is recognized in time. Case 5 was a 56-year-old male, complains of floaters, 2 months associated with diminution of vision. Vision was 6/9 in both eyes, cells were 1+ in anterior chamber, fine KPs. VDRL TPHA turned out to be positive with elevated ESR. This patient was diagnosed as syphilitic intermediate uveitis. You can see that on FFA, there is a diffuse leakage of the vessels, there is a disc leakage, there is a little bit of few cystic spaces on OCT. In this case, FFA was diagnostic along with the lab investigations, and here the treatment was given where the standard treatment is IV benzathine penicillin, which is given for 21 days, but sometimes because of the unavailability, IV ceftriaxone can be given for 14 days with good outcome. So in this case, the optic disc involvement was in the form of hyperemia, which stems from inflammation induced by the upregulation of VEGF, although there was no direct involvement due to mass lesion or due to adjacent infiltration. Case 6 was a 21-year-old female who presented with deep-seated right eye pain associated with diminution of vision. Systemic history was significant with a single episode of hematuria. The vision was 360, left eye was normal. There was conjunctival congestion, and we can see that there is presence of focal exudative pocket of retinal detachment with some fibrinous exudate in the subretinal fluid. The B scan showed a T sign, and the FFA shows some stippled hyperfluorescence at the posterior pole along with disc hyperfluorescence and staining. This case turned out to be ANA positive, P-ANCA positive, and she was diagnosed as having posterior scleritis secondary to P-ANCA mediated vasculitis, started on systemic steroids and rheumatology referral for further management. So optic nerve involvement in posterior scleritis is secondary to surrounding inflammation in adjoining tissues, in this case, which is sclera. My last case is a 9-year-old boy with progressive diminution of vision in both eyes, systemic history significant for T-cell acute lymphocytic leukemia. He was a defaulter with chemotherapy, right eye was denying PL, left eye was 660, and there was presence of leukemic optic nerve head infiltrate with combined vascular occlusion and infiltrative exudative retinal detachment in both eyes. Optic nerve head involvement in such cases, they are secondary to neoplastic infiltrative disorders, and this may often be the first presenting sign of systemic malignancy. Takeaway points from all these cases is that optic nerve involvement, it is an integral aspect of uveitis and should be looked for in all cases. Optic nerve involvement in uveitis runs the gamut of presentations from compressive, reactionary, infectious, and infiltrative, which I have elaborated in my case illustrations. Identification of such involvement patterns facilitates prompt diagnosis, which serves as a diagnostic value. Targeted treatment serves as a therapeutic value, and improved prognosis serving as a prognostic value. Just a few more points. Last slide. Neuroretinitis with optic disc involvement is frequently of infectious etiology. Elevated optic nerve head may be the only sign on B scan of a panuveitis with poor fundus visibility. Optic nerve involvement can present as simple hyperemia, slight blurred margins, frank disc edema, or optic atrophy. And appropriate investigations may be employed on case-to-case basis to detect and monitor B scan, OCT, OCT-RNFL, and FFA, etc. Thank you so much.
Thank you, Samendra, for doing justice to such a difficult topic. I would like to invite Dr. Balamurgan sir for the discussion. How would you differentiate between optic nerve swelling due to uveitis and other potential causes such as papilloedema or optic neuritis?
Thank you for inviting me for this nice discussion. The answer is very simple. Look for the associated clinical pointers of inflammation, starting from anterior segment, the sheathing of the vessels, the associated choroidal or retinal lesions. They can point towards an inflammatory etiology. For cases in dilemma, of course, as Samendra has pointed out, the imaging modalities like FFA with the classical pointers of inflammatory disc leak, and of course the OCT and OCTA, not to forget the B scan is going to be really, really helpful in dilemma cases. And most importantly, so some of the things which we don't pay attention is the spontaneous venous pulsations. none of us nowadays are observing the direct ophthalmoscope. Those beginning period, we used to observe for those subtle signs. Of course, the magnitude of elevation and the pattern of elevation all give us a pointer towards ruling out an uveitic pathology from a papilledema. However, there is in this question you also said that optic neuritis, you will have a pointer from the RAPD, and in addition to that, an inflammation could extend to the adjacent layers. For example, what was initially an uveitic pathology can transcend to the next layer involving the optic nerve. That will have a great impact in the further plan of treatment. So things are not definitely delineated into compartments. There can be an extension of inflammation, as Dr. Basu was saying. A choroiditis can go on to a scleritis. Similarly, an uveitic pathology can transcend into a optic neuritis in the if the titration of the treatment is not properly done. So we should always be ready to change our impression based on the subtle points which we observe. Hope I answered the question.
Thank you, sir.
Thanks, Bala. I think it was a nice point. Now let me invite Dr. Abhilasha Baharani with the most dreaded clinical signs of uveitis, that is retinitis. So Dr. Abhilasha Baharani is a dedicated UVA specialist at New Retina, Hyderabad, and who has a decade of experience in treating uveitis patients. As an active member of the Uveitis Society of India, Dr. Abhilasha currently serves as editor-in-chief of the USI newsletter, and all of you must have already seen the newsletter she has brought. So, and she has received many awards and published a lot of articles in various national and international journals. Over to Abhilasha.
Thank you so much, Dr. Partho, for the kind invitation, and I thank you for putting in so much effort for this session on walk-in uveitis patient. I'll be talking about retinitis, decode the clinical signs. So retinitis is mostly infectious. So in this talk, I'll try to cover viral, bacterial, fungal and parasitic causes of infectious retinitis, and non-infectious retinitis. The most prominent is Behçet's disease. So starting with acute retinal necrosis, it is a necrotizing retinitis characterized by full thickness retinal necrosis in the peripheral retina with or without inflammation. We see white to yellow retinal edema and opacity with or without hemorrhage, as seen in this picture. On healing, we see an atrophic or gliotic scar. This case did not have a lot of vitritis, but generally the vitritis is little severe in ARN, just like in this case. Here you see circumferential confluent retinitis and retinal vascular occlusion. And this is following treatment. This patient needed laser, extensive laser for the ischemia. Sometimes the vitritis is very severe and we may hardly see the retinal findings. In such cases, there should be a high index of suspicion and the diagnosis should be confirmed with a PCR. And these patients should be closely followed up because they might develop a retinal detachment, as in this case. This patient had a shallow retinal detachment, and this is the clinical picture after the VR surgery. Now, this is a case of a retrovirus positive case of ARN. Again, we see hardly any vitritis, and the peripheral OCT shows full thickness retinal necrosis in both the eyes. So the classification criteria for acute retinal necrosis according to the Sun Working Group, necrotizing retinitis involving the peripheral retina and either a positive PCR or a characteristic clinical picture of circumferential or confluent retinitis, retinal vascular sheathing and or occlusion, and more than minimal vitritis. The exclusion criteria is a positive serology for syphilis. Coming to cytomegalovirus retinitis, this is again a necrotizing retinitis with indistinct borders due to numerous small satellite lesions. As seen in this case, we see a wedge-shaped area of hemorrhagic or granular retinitis with mild or no vitritis. This is the other eye, which has a frosted branch angiitis-like picture. Nowadays, we see a lot of cases of CMV retinitis in cases of post-cancer chemotherapy. This is one such case where we see bilateral CMV retinitis, and though it's not severe in the right eye, the macula is involved, and this is following healing. There are certain typical OCT pictures that we see. There is full thickness retinal necrosis. This is cavernous retinal necrosis, where you see loss of tissue within the retina, and there is thickening of the underlying choriocapillaries. And on healing, there is loss of retinal tissue. Now, this patient was a case of bilateral macular hole and was advised VR surgery. But if you see the periphery, you see CMV retinitis lesions. Now, this patient is again CMV retinitis post-cancer chemotherapy. And whenever you see such cases, it's very important to look at the periphery before taking a decision to operate such a case. Coming to classification criteria for CMV retinitis, now it requires criteria 1 and 2 and either of 3 or 4. So necrotizing retinitis with indistinct borders and immunocompromised due to any reason, and either a characteristic clinical picture with wedge-shaped area of retinitis, hemorrhagic appearance of the retinitis, granular appearance, or absent or mild vitritis, or a positive PCR. Again, a positive serology for syphilis is an exclusion criteria in this case too. Coming to toxoplasma retinochoroiditis, most of the speakers have spoken about it. So the typical lesion is a focal retinochoroiditis with prominent vitreous cell haze, what we call as headlight in fog. In this case, the vitritis is not prominent. And here, if we see the typical OCT picture, which helps in the diagnosis, so there is prominent inner retinal hyperreflectivity, full thickness retinal disorganization, and underlying thickening of the choroid. Healing is with atrophic scar, and a thickened posterior hyaloid is seen. Now, this is a case of a large lesion with prominent vascular sheathing. Here, if you see, again, there are hyperreflective oval deposits on the surface of the retina, and there is thickened posterior hyaloid, which is attached to the active lesions, and it is detached around it. Again, healing is with scarring. Punctate outer retinal toxoplasmosis is a variant of this disease, where we see multifocal gray-white lesions at the level of the deep retina and retinal pigment epithelium with minimal vitritis. This should be distinguished from the white dot syndromes. You see areas of hyper and isoautofluorescence in case of active disease, and healed areas show hypo autofluorescence, as in this case. OCT findings are very typical. There is inner retinal hyperreflectivity and thickening with minimal vitritis, and there is disruption of the ellipsoid and the interdigitation zones, and focal splitting of the RPE and Brooks membrane, as you see in this case. Outer retinal atrophic scar is seen with increased choroidal transmission on healing. Now, these scars are often inactive cysts of the parasite, and these should be carefully followed up. Coming to post-fever retinitis, it can be caused by rickettsia, chikungunya, West Nile virus. It is acute onset multifocal retinal infiltrates following a flu-like prodrome. So there are varied clinical presentations. You may see a picture of multifocal retinitis. Sometimes it is accompanied with a branched retinal artery occlusion, and a macular star is typical. This is another case where you see inner retinal thickening and hyperreflectivity with subretinal fluid. Healing is characterized by retinal thinning. When we see a case of active post-fever retinitis, there are often you see these shadow artifacts on octa. But on healing, you see true flow voids or non-perfusion in the superficial and deep capillary plexus, because most of these organisms have a very high affinity for the retinal vasculature. This is a typical rickettsial maculopapular rash. And these patients, even with treatment, because of the retinal ischemia, they have very severe field effect, and these should be monitored. Coming to fungal or Aspergillus endophthalmitis, here in this case, we see a case of dense vitritis with typical feathery margins. This is the intraop picture showing multiple areas of retinitis. Now, Aspergillus has a very high affinity for the RPE because of its high oxygen content. And here you see a case of, you see the outer retinal hyperreflectivity, and there is a well-defined bowl-shaped area of hyporeflectivity in the choroid. So this is probably a chororetinal abscess. Coming to syphilitic retinitis, you see a hyperemic disc, ground glass retinochoroiditis, and very typical superficial retinal infiltrates in this case. There is dense vitritis, intraretinal hemorrhage, and again, in the other eye also, you see these typical superficial retinal infiltrates. On FFA, the hypofluorescent edge of the posterior placoid lesion is seen, and a perivascular leak shows that this patient has active vasculitis. OCT findings are typical of nodular thickening of the RPE and disruptions of the external limiting membrane and the ellipsoid zone. Coming to Behçet's disease, this is the most prominent non-infectious cause of retinitis. It is a bilateral recurrent non-granulomatous panuveitis with transient retinal infiltrates and vasculitis. This patient has bilateral retinal infiltrates both in the posterior pole and the periphery. A mobile hypopyon is very characteristic. These cases are very deceptive because you might feel, looking at the fundus picture, that you have given very good treatment and the infiltrates are all gone. But if you see the fluorescein angiogram, you will see characteristic fawn pattern leak. So FFA should be the main modality to monitor response to treatment in this disease. To summarize, retinitis is mostly infectious. Diagnosis is often clinical. Imaging helps us understand the level of the lesion and is useful in monitoring response to treatment. Thank you.
Thank you, Abhilasha, for a wonderful talk on retinitis. I would like to invite Dr. Bala Murugan sir and Professor Ramandeep Singh for the discussion. Can you give some words of caution to the treating ophthalmologist managing a case of retinitis?
So I'll take the question first. Retinitis, as a clinician, we have to be very careful in ruling out infections, as it was been multiple times mentioned. So the word of caution is, as you rightly put, is to avoid giving postisubtenon and intravitreal steroids without ruling out infections. A lot of times we directly jump in and give the treatment without doing tests for syphilis or without ruling out infection like viral cause of ARN and peripheral retinitis. Because the media is hazy, don't jump in and pump in full dose of steroids. That is a word of caution. And because by doing that, what will happen is, I had one case of intermediate uveitis because of poor media clarity. The treating doctor directly started with intravitreal steroids, And the syphilis is a non-necrotizing disease process. If you pre-treat it with intravitreal steroid or a periocular steroid, the non-necrotizing disease becomes a necrotizing disease process. So it becomes very challenging, and the outcome also might change. So that is the first takeaway. And apart, the second caveat as a treating physician is we are very skeptical of ruling out infection because it is easily said, rather difficult to do, because there are so many infections that could present as retinitis, starting from the emerging viral and newer viral infections. However, we should also think in terms of non-infectious cause of retinitis, and a clue could come from the FFA. If it is a non-occlusive form or non-leaking form of retinitis in an angiogram, be very careful. Are you dealing with a hypertensive retinopathy, or there could be some hemoglobinopathies, multiple myelomas, masquerades, where the FFA is going to be really, really helpful. If there is a retinitis with no vessel occlusion or vessel leak, be very, very careful to look for them as well. And don't be carried away and keep on treating as normal infectious stuff. So, and even the masquerades could sometimes mimic as retinitis. These are the two pures I thought I'd share with you.
Thank you.
Yeah. I think Dr. Bala has elaborated most of the things, but one thing I'll add here is, once you see this sign in the eye, now is the time for the retrospective history. Go back and ask some, questions there actually, because you can't ask everything. I think in uveitis it's very important to take a retrospective history. See those signs and then ask what is happening there. That is, I think, the most important. The patient will tell you the diagnosis if you ask him the correct question. He will tell you that I am immunocompromised. He'll tell you that I have visited to a jungle, or whatever you want to know. He will tell you that kind of a thing. That's all I have to add. Yeah.
So that was a really an important point, to retrospectively after examination asking the history again. What is your imaging of choice in a case of retinitis?
Yeah. So nowadays, in the case of retinitis, if we have to treat a patient without doing OCT, it becomes very challenging because we have to show the patient the severity of the problem. As our teachers have taught, earlier they used to believe the histopathology slide. Now I don't look OCT as a OCT. I think in terms of doing a histopathology of the layer of the retina. You can precisely point out which layer you have a disease process, based on which your particular etiology, or you can zoom into a particular set of differential diagnosis. For example, in emerging viral, you will have a preference of, say, an inner retinal layer or a toxo. When you have a particular layer involved, if there is a full thickness involvement, there is a beautiful tabular column again pointed out in the USA newsletter. You can go and look at the differentiating the etiologies based on the OCT. OCT will be my first investigation of choice. Apart from the layers, I will also look at the autofluorescence part as well, because during the down course of treatment, the autofluorescence will also guide me to suggest the healing phenomena as well. And if needed, I will not hesitate to do the other investigations, as Dr. Abhilash has neatly pointed to, the OCTA and FFA and ICG as well. Of course, the first imaging will be OCT in my hands.
Yeah. Again, Bala, I think if you have I would add, if you have a wide angle imaging, fundus photo will be beneficial for the patient. And of course, a baseline FFA we always do. But later on, when we follow up this patient, just a fundus photo and OCT will be able to tell us that what is happening there. I mean, people have now studied the abnormal and the normal part of the retinitis, and to predict that this eye will develop a retinal detachment. And that is the further things, but a must is a fundus photo and a OCT while managing these patients of retinitis. That's right.
Points well noted, sir. I would request Dr. Partho, sir, to conclude the session and give the vote of thanks.
So thanks, Rohit. So on behalf of team AIOS, Dr. Rohit and from me. So I thank all the speakers, panelists, and all of you who are watching this webinar live or will be watching it later on the YouTube. Stay connected with the AIOS One YouTube channel for more educational webinar. Good night. Good night, everyone.
Artho, wonderful job.
Good night. Thank you, sir. Good night.
Thank you, sir.
Artho, Rohit, wonderful
Good
job.
night.
Thank you.
Photo request
I enjoyed.
Dr. Richa Neetu to come. Anup. Richa. Neetu, are you there? Anup.
Yes, sir. Just a second.
Can you just come online?
Yes, sir.
Yeah. Anup, can you switch on your video? Yes. Thank you. Yeah.
Thank you.
Thank you so much. I really enjoyed each of the questions.